Hello and welcome to today's American Academy of Neurology webinar, Key Considerations for Reopening a Neurology Practice. We have great diverse perspectives on today's webinar. We have 3 neurologists and 1 advanced practice provider. They all serve on either the Medical Economics and Practice Committee or one of its subcommittees, including the Coding and Payment Policy Subcommittee and the Care Delivery Subcommittee. Dr. Gurdesh Bedi is a solo practitioner who manages medical and musculoskeletal practices in a rural and suburban healthcare system in the outskirts of the Twin Cities of Minneapolis-St. Paul. Dr. Alan Gee has a small rural and virtual general neurology practice in Wyoming. He's the founder of Frontier NeuroHealth. Dr. Mark Mintz is Chief Medical Officer and founder of NeuroAbilities Healthcare, which has facilities throughout New Jersey and Pennsylvania, and is an independent multidisciplinary organization providing neurological, neurodevelopmental, and neuropsychiatric diagnostic and treatment services to individuals and families across the lifespan. And Dr. Melissa Ryder-Deemer manages patients with stroke, epilepsy, and general neurology among outpatient and transitional care venues. She is a pioneer at UCLA using telehealth and launched the use of video visits in neurology. Today's webinar will feature key resources and considerations for reopening your neurology practice. If you have any questions outside the scope of this webinar, you can send questions about practice management, coding, and reimbursement to practice@aan.com. And with that, I'd like to turn the presentation over to Dr. Bedi.
Hi everyone, welcome to AAN's webinar about key considerations for reopening of neurology practices. We'll roughly address the following topics. Today, we'll talk about general operations and operational guidance. We'll talk about safety and PPE equipment that is available to us, also about cleaning protocols and equipment. We'll talk about scheduling. We'll talk about workforce management. We'll talk about testing, whatever we know about testing, and we'll talk about how to communicate all of this to our patients and how to set the right expectations towards our patients. After that, we hope to have a decent, nice Q&A session where we'll address all the questions that you have. This content is made available for voluntary and informational purposes only. I want to emphasize that this is the work of a task force that was created by the Medical Economics and Practice Committee of the American Academy of Neurology. You were introduced to the members of the committee a minute ago. This does not reflect the views of the AAN itself. There is a toolkit that accompanies this presentation as well, and that has also been created by this small task force helped by AAN staff. So I'd like to jump right into the conversation about reopening our practices. To understand why we are even talking about reopening practices, we need to go back a couple of months and understand the history of COVID as we've seen it over the last couple of months. I know this is a little bit of an overbearance, but if you would stay with me, there are 4 curves on this slide that I'm displaying right now. The first curve, the purple curve, is the COVID curve that everybody has focused on so far. In December, a new kind of pneumonitis appeared in China, and we did not really understand the cause or the effect of that kind of pneumonia. In January, we identified that this was a new mutant of the coronavirus family, and we named it the COVID-19 pneumonia and identified the underlying virus as the SARS-2 coronavirus. In February, cases grew in most of the world. China had a big increase in the number of cases, while the epicenter of this epidemic moved from China to Europe. WHO declared this as a healthcare emergency, and we saw the first cases appear in the United States towards the end of January, and we saw a spread of this coronavirus throughout all states by the end of February. In March 2020, I want to say that March 2020 was a very transformational month for all of us. We all understood the gravity, the virulence, and the pathogenicity of this virus, and we all transitioned from our traditional in-person patient management to telemedicine as a primary method of communication with our patients. I want to say that I would commend the AAN in helping us, and I would commend all of our institutions in ramping up our telemedicine capacities very rapidly through this very necessary time. That has increased in the month of April. The month of April saw the appearance of the CARES 2 Act, which allowed us funding and other institutional support to roll out telemedicine in a big way. And we have now seen neurology practices switch over to a tele-platform-based practice method of communication to a very large extent. That will probably continue going forward. What has happened as a byproduct of this transition, this rapid transition onto telemedicine, is that we have treated the COVID epidemic as a switch on, switch off kind of a process, where we switched off all in-person visits and transitioned most of our care into telemedicine. There has been no formal neurological study that I've read about this, but there's been insurance data that has crept out. There's an article today in the Wall Street Journal where Cigna has reported a 31% reduction in TIA presentations to emergency rooms and a 28% reduction in seizure presentations to emergency rooms. What we are noticing is that as we have transitioned to a telehealth-based neurology practice, we have cut down the in-person visits towards our patients quite drastically. And that has led to this new problem that seems to be emerging, which is that of the green and blue curves, if you notice on this cartoon. The green curve represents all the care that is being deferred because of transitioning away from in-person management. And the blue curve represents the impact of the delay in that care. This would be your TIA patient who had a 2-minute episode of amaurosis fugax and could have had an endarterectomy in the month of March, who now presents with a much bigger stroke from carotid occlusion in the month of July. So those are the kind of things that we are talking about. What makes it even harder to predict is the lack of good modeling about this disease. We have several models that are floating about. It is difficult to be very predictive about what the trajectory of COVID infections would be going forward, which makes it very hard for us to actually predict what the month of June, July, August, what this fall, and what next year would look like. This uncertainty basically brings in a new paradigm of this necessitates a new paradigm of looking at the way we practice medicine. We have understood so far that telemedicine is very important. We have also understood that there are gaps in telehealth, and there are some patients who need to be seen in person, and there is a need for us to selectively open our practices to meet those unmet needs. How and when we will change those gears will probably be a very fluctuant and, quite honestly, a very back and forth kind of process. Depending on the infectivity of this virus and depending on the infection rates of this virus, we might open our practices, slow down our practices, open them again, but there'll be a lot of back and forth in the next year. So the key messages for the next year or so would be to remain flexible and strategic, obviously follow federal, state, and local guidance on a regular basis, evaluate your local situation and data before reopening, continue to practice telemedicine as appropriate, update your professional liability carriers about reopening, and obviously have a plan to open your practices gradually and also have plans to manage future opening and closing states going forward. What I am sharing here is one of the several models that exist to help manage this fluctuant and this constantly changing landscape over the next year. This is a model that we created in our institution, and I'm sharing it with you. Several states have had similar kinds of red, yellow, and green ratings. Other states have used a pendulum analogy. The state of Minnesota, where I live, uses a dial analogy where we talk about dials opening and closing. But that's exactly the landscape that we'll be living in the future. What we do, what all of these analogies, what all of these paradigms look at are basically 4 different factors. The first factor that you need to consider when you decide on an operational level for your institution is to look at the amount of COVID activity in your state and more importantly, in your local geography and region. We have chosen in our institution a 4-county area as our local geography, but then we also monitor, being on the border of 2 states, we monitor the 2 states and their COVID infection rates very regularly. This data is available to all of you through your Department of Health. I think that most states have a very open website. If you simply Google Department of Health of your state, you will know the number of COVID infection patients. Most states have hospital data and ICU utilization rates on those websites. So that's freely available data. The second factor to consider would be the resources at your state and local geography and referral center levels, which basically means, does your state or your local geography have the capability of handling hospitalizations and ICU patients should there be a surge? The third thing to look at is your internal resources. Do you have PPE? Do you have supplies? Do you have staff to manage patients in case there is a surge? Do you have all these supplies to prevent propagating this disease and keeping your staff safe? So your stockpile becomes an important factor. And the fourth thing, obviously, that we all monitor are regulatory and other forms of guidance that's coming through the states. The way we function is to put all of these in a grid and to use the least common denominator while defining the operational level of our institution. So for example, the first stage of this table, the time frame, looks at the doubling rate of infections. We look at infections because tests are quite freely available in our area at this point. You might use hospitalization rates or ICU rates as surrogates for infection rates if testing is not freely available, but we look at the rates of infections. Second, we look at our internal resources. Third, we look at and we look at state ICU availability, and then looking at that, we define what our operational level should be. Defining this operational level allows all teams of our institution to be prepared every day to change the way they work. What I mean by that is that it is not possible for us to live in the last 60 days for the next year or so, which means that in the last 60 days, we had several meetings where we called department heads together, we scrambled for data, we defined data sometimes in different ways as compared to our previous data definitions, and then we came up with a decision. Defining a daily threat level allows us to put a high level label on the workings of our institution, and then different teams and different departments utilize that to see what state they'll be working in, whether they'll be a red, yellow, or a green level state of operations on that particular day. Once we have that data and that guidance from our institutions, we then use that and pass that information over to individual teams and individual physicians so that they can then use that operational state and then superimpose individual patient status on that to define whether a patient needs to be seen in person or should we continue to monitor them remotely via telehealth. This is a simple equation that we have tried to draw up to try to define whether inpatient or remote care is appropriate for a given patient. What we want everybody to think about are 2 kinds of risk. The last 60 days were spent talking about COVID risk. We somewhat ignored the risk of, I shouldn't say ignored, but I think the risk of patient worsening kind of took a slight back seat to the risk of COVID transmission. I think now, as time is passing, patients who could have been deferred now are becoming more important. And the risk of not intervening of them is piling up. And as that risk of non-intervention piles up, at some point it becomes bigger than the risk of COVID transmission to and from these patients. And that is when these patients should be seen in person. When I talk about this, we're talking about all kinds of inpatient visits. We're talking about inpatient clinic visits. We're talking about EMGs and EEGs. We're talking about all sorts of procedures that happen. We're talking about imaging. And all of those need to be put in that same equation of whether the risk of COVID transmission from a patient is more or the risk of not intervening on a patient is more. And once we define that the risk of not intervening is actually the greater value, then that patient should have their appropriate procedure, whether it's a clinic visit or a diagnostic study or any kind of intervention. There are some factors that go into individual COVID risk. Of course, your local geography is important, but superimposed upon that are individual risks such as increasing age, your cardiopulmonary status of the patient, renal failure, diabetes, obesity, all of those factors that we know can worsen the infection in a particular patient. That list is available on the CDC's website, and we've attached a link to that here. But there are several calculators that have been devised. We did not have time to validate any of those calculators. So you can punch in numbers into a calculator and get a rough score at the end, or you can use these factors to define whether a particular patient might be more at risk from COVID transmission as compared to a different patient. The non-intervention risk, this has been defined in surgical groups much better than in our group. And the simple reason for that is that surgeries can be classified into 3 or 4 major buckets. So it's easier to define and calculate the risk of not doing a cholecystectomy on a given patient. So American College of Surgeons has a very nice calculator there. I'm hoping for a clinic visit calculator that could come out soon. But there are other kinds of calculators that you can devise their own. Pain medicine has a calculator to devise whether somebody should be intervened upon or not, but we couldn't find one that would work so easily for neurology. So we would have to make that judgment on our own. If it's a 54-year-old healthy gentleman with his second TIA in the last month, I think that patient obviously should be intervened upon at this time. Whereas if it's somebody who is older, has cardiopulmonary ailments, and hence the COVID risk increases, you might not want to call them in for a back pain visit or a procedure, because the risk of non-intervention is probably going to be lower. So those are the kind of high-level guidance thoughts that should be in our minds when defining the operational status of our institutions, while defining the COVID risk of a given patient, and also while defining the risk of not intervening on a given patient. And using these equations, we can figure out whether the risk of not intervening or the risk of calling the patient into our clinics is higher. Now, all of this is only relevant if we can actually take all this and operationalize it. The next 2 speakers, Dr. Ryder-Deemer and Dr. Mintz, will talk about the operational aspects of reopening our practice. So I'll pass it over to Dr. Deemer.
So I'm going to go over safety, scheduling, and workforce components. We're going to spend a little bit of time on this slide in particular, because we do need to address, how do we establish safe and effective patient screening, coupled with how to schedule them and navigate that prior and the day of, how to make sure you have appropriate PPE supplies for that given day. Making sure you understand that there's in your workflow how to sanitize the patient rooms and instruments, for example, throughout the day, while minimizing contact and being respectful for social distancing. In addition to just making sure that your practice supplies is there, including medications, but always being mindful of the building safety management and guidelines. So I think what it's important, just to allude on what Dr. Beatty was saying, was that what we're trying to create is a transitional hybrid model of care delivery, and including a combination of in-person and virtual visits. And throughout this hybrid rollout, we simultaneously need to adhere and be respectful for social distancing and being mindful of what the PPE available to your respective office or practice or institute. And it's constantly scanning and surveilling all those variables on an ongoing basis. Even simple things such as daily huddles, having that the night before and looking at, okay, who's scheduled the next day? What is the staff ratio we need to do to support that? How will the flow happen with the staff ratio? Being mindful of the social distancing when the patients arrive, how do we navigate them to avoid any additional interactions that they may have with others that are waiting, and being mindful that we have, the least amount of contacts as possible, in addition to making sure that you have the appropriate PPE for the individuals coming in. So for screening and scheduling, oftentimes, we've always tried to accommodate with the patient's preferences. But as Dr. Beatty referred to, using those red, yellow, and green pathways, and then the formula with determining, what makes sense with the risk analysis for the patient is something that you have to be mindful with when you're scheduling the patients accordingly. When you're scheduling the patients, it is a good idea to also have the staff inquire. Do they have any symptoms or fever at that point in time? If they're experiencing a symptoms or fever, depending upon where you work, it may be that you need to redirect them at that point in time. If it's an academic center, it may be a command center where you would hand it off to them and they would contact the patient, oftentimes via video visit, and then determine if testing is needed or an in-person visit for their symptoms, or just simple guidance from the virtual visit. Or if you're in private practice, it may be referring them to the primary care provider or local testing site. Now, when patients arrive, you have to be mindful that you need to have a screening area. Oftentimes, it's an individual that is in the PPE that is at a table, and there's designated laminated cards that are 6 feet apart, and the person checking in will prompt the individual as to when they go forward for the check-in process. Typically, it's a laminated card that is in very large print, asking questions like, have you had diarrhea, muscle fatigue, the runny nose, cough, fever, and asking them if they've had any of those symptoms. Typically, recently, we've been asking patients if they've had any of those symptoms in the last 7 days. For providers, oftentimes it's the same questions that they're being asked every day, and oftentimes it even can be organized within a toolkit. It may be an iPad or an email you get every day that you log in and they ask you, have you had any of these questions? And it's attached to a HIPAA compliant provider ID. Depends upon where you work, but providers and patients each day need to be screened. In addition to those questions, you typically are using an infrared temperature to make sure that someone doesn't have a temperature before they're entering that area. And by using the infrared option, you're not making any direct patient contact with everyone. And the individuals that are screening are typically wearing the PPE appropriate as they're checking in the individuals. Now, let's say that as you're checking them in, as I alluded to a moment ago, they have some of those symptoms and or fever, then at that point in time, depending upon where you work, again, you would dictate it to as the command center, as I alluded to a moment ago, or it could be to the local primary care or local testing, depending upon your respective workplace. If they're not having any symptoms or fever, then you progress to the visit. Now, there's a number of ways to facilitate some of these different options that I'm going to share with you. But one thing is copay. How do you obtain that, and how do you receive that in a normal flow process? If you can get the copay from the patient while you're scheduling the patient on the phone, that would be most advantageous. If not, there's usually an additional check-in screening area, and sometimes people are using plastic shields to cover that up. It may be that the individuals in the PPE receiving them as the screeners do, but you can receive a copay, being mindful as much as possible with social distancing during that time. Depending upon if you're in an office or private practice or an academic center, how you escort the patients in and out of the appointments can greatly vary. So in some areas, if you're in private practice, it can be that an individual is waiting in the parking lot and they have a list of who's coming in, what times they are, their names and what they're there for and who they're seeing. And they're greeted in the parking lot and they check them in because they have the list and they ask them to wait there. And then when their time has come up in a succinct pattern, there's different laminated cards that are down typically on a floor with arrows that are 6 feet apart. And then you sequentially will guide the patients into the setting and then direct them at that point in time into the patient room. Other options can be that once they're checked in, there is an entrance coordinator that will walk them directly to the patient room. It also could be that you have a waiting room and you will set chairs up 6 feet apart with laminated signs that says, please patients sit here. Then after each time they leave, you need to clean and sanitize that seat down, waiting 5 to 10 minutes in between when the next patient can use that seat. Now, in any of these scenarios, there needs to be or suggested an entrance and an exit coordinator. So it's the same individual that's going to be escorting the patient to the room as well as exiting them from their appointment. This is to decrease contacts, being mindful of social distancing, but also protecting the patients that they don't get lost in the shuffle or whatnot. And, just even in air sometimes would interface with other patients during that time. You have to be sure that all the rooms and all the instruments are sanitized after use. And you should be waiting 5 to 10 minutes in between reuse for all of that. And that is somewhat cumbersome, but it's necessary. So if you use a reflex hammer, your stethoscope, you need to clean that down. We're going to get into equipment a little bit later, but all of those measures need to be executed at all times. When the patient's done, it is suggested to, again, have that same exit coordinator with their discharge after visit summary in hand and escort them out. And these are just some suggestions during that point in time. For PPE, at the bare minimum, providers and patients should be wearing a surgical mask, but obviously there's different aspects and different situations that might require a higher level of care of that. Following me, Dr. Mins is going to get into PPE, so I think I will allow him to take that over just shortly with more specifics on that. But also just being mindful that washing your hands for 20 seconds oftentimes, in addition to the sanitation that we just spoke of, is pretty crucial during all this time. Additionally, you do need to be mindful of the patient management safety guidelines. You need to be aware of what those respective measures are and enforce those. In addition to making sure you have your medications available, what is in your crash cart? Is everything up to date and not expired? Do you have Ativan, do you have Narcan and whatnot, and other measures that you may need? So scheduling. Developing a system which patients should be seen in person versus telemedicine. As we said, we're in this hybrid protocol of balancing all of that based on the community and patient risk factors that Dr. Beatty did refer to in the red, yellow, and green guidelines, again, with that calculated ratio as well. Implement pre-visit screening for in-person appointments, assess how scheduling and procedures will affect the use of sanitation and PPE, and the extent the hours may need to be flexible. So when we're developing a system to determine which patients should be seen in person for telemedicine versus video visit, which is the hybrid that we alluded to, again, I do want to keep reiterating the red, yellow, and green and the calculations that Dr. Beatty referred to. But oftentimes you need to look at what your practice is at what it was prior to all this at full capacity and try to start with a 25% scale up mentality. And see from that 25% with the red, yellow, green, and the calculation guidelines, who does need to be seen in your eyes as your professional opinion as a provider amongst your different programs that you have. And once that is done with the 25% scale up, you need to then say, okay, how do we need to staff this? What is the ratio for staffing? You know, does everyone need to be here in person, and how are we going to manage, and where will they be sitting and welcoming patients to maintain and respect the social distancing? Or once we see patients in clinic, you know, could there be a mix? Could there be some people that are still working at home doing certain tasks and other there in person on a rotation basis? Again, trying to keep the number of interactions down and being mindful with the social distancing. Providers need to direct staff and have very open communication with who and when the patient should be scheduled. You need to make sure you have video visit slots and in-person slots. You may adopt to do this on a certain patient population that needs to be seen versus individual patients that are just sort of at random, but you're worried about them. You need to delineate a process with all these components and have direct communication with your coordinators and staff so that they are clear on how to schedule these patients. And it is suggested that you daily work with them and see who's been scheduled, you know, how are they feeling these days, and who is scheduled the next day. And again, making sure staffing ratios, PPE is there, and that the risk analysis is in place. Suggestions such as being mindful to those with immune compromise or those that are elderly. You may want to consider, if you feel that they need to have an in-person visit, that they be scheduled the first of the day. That'll be requiring less interactions, and there's been more time for the rooms to sort of breathe in between. All of us are going to have to be flexible during these times. You know, we may need to have new early morning slots. We may need to have late afternoon or evening slots, or even possibly weekend slots. Being mindful that if you use video visits for early morning and late afternoon and on the weekends, you don't necessarily need staff to check in those patients. So again, when you're working at the ratio and how to mandate all that, you might want to be mindful with all of that. Or sometimes it may even be splitting staff and flexing them so that we, you know, have some programs in the early morning and other programs in the afternoon, and being mindful for the least number of people, but making sure that the patient's needs are being met at all those points in times. And again, I cannot emphasize enough for reviewing with your staff on a daily basis. So workforce. Developing staff policies, returning to work, of course, complying with federal guidance if staff member contracts COVID. There are some links here that we can allude to at the end for the CDC and OSHA. They're not, you know, specifically necessarily written out because this is a moving target, but they are very useful to help you guide in your practice. Discussing changes to providers and supportive staff with the ability to return to work, and establishing frequent, as I said, and open communication with your staff. So policies may vary based on practice and respective institute. You know, your risk in one state may be very different than the risk of another state. Your individual practice may have a higher level of risk of vulnerable patients versus another provider. So in dictating, you know, the hybrid model between video visits and in-person has to be on the risk analysis that we have alluded to. The 25% projection seems to make sense from a business sense, so you can determine what that was to you, as I had mentioned earlier. And then the staffing ratio, you can constantly assess and reassess. So as you scale up and are successful with the first phase, you can add on 25% more. And then again, assess and reassess what staff needs to be there. Who is the exit and entry coordinator? How are we going to be mindful with the social distancing as we scale up? And who does need to be on the premises versus continuing to work at home? It may be that office individuals will continue to rotate. Some may be working at home some weeks and then rotate to others later, and being mindful of that and trying to be fair with all of that. But it's what we have to do sometimes to accommodate the space, to be mindful for the social distancing with all of that, and having the flex schedule really is essential. You should follow the universal mask guidance. You know, everyone should be wearing a mask at all times, patients and providers. And again, Dr. Mintz shortly is going to get in more specifics with the PPE and share some of the CDC guidelines to allude to, and that'll be resource links at the end. Being mindful that providers and anyone in clinic should be there only for the purposes to see patients. Sometimes in the past, a lot of us are, writing notes and making phone calls using a room in clinic. And at this point in time, it needs to be for the individuals that need to be there and seen, and everyone else should not be there doing those methods at that point in time. They should be doing those respective practices elsewhere. And again, I do think you need to be very mindful with how the patients are being escorted in and out, and making sure that the contact is somewhat limited with all of that.
So we'll start talking about personal protective equipment, or PPE. PPE are barriers to virus, and the purpose is to reduce the risk of infection and transmission of virus. The PPE are basically protection for healthcare providers, but they also are used for source control, that is, blocking either respiratory secretions or other viral sources from contaminating other persons or surfaces, whether it be from healthcare provider to patients or the reverse, patients to healthcare providers. But PPE do have limitations. They should not be used as a substitute for hand hygiene. In fact, it's a good idea to wash your hands before and after wearing PPE and utilize good hand hygiene at all times. When to use PPE, what type of PPE, and how much PPE to use is guided by the concept of universal precautions. This is something everybody is quite familiar with, and is something that has been utilized in healthcare facilities for quite a long time. In this present climate, this will be based upon your community prevalence of COVID-19 virus. It'll also be guided by the level of patient contact you might expect in a certain situation. And additionally, the risk of aerosolization based upon, again, patient analysis and the type of procedure or interaction you might be having. You should, for your practices, create staff training, refreshers, policies and procedures, even for simplistic things that you might take for granted, like the proper placement and use of PPE and the safe removal and disposal of PPE, so you can prevent self-contamination or environmental contamination. You might also want to consider creating different types of PPE kits, if you will, for different types of staff, and even for patients and patient room availability, so it's accessible. Now, one of the big issues for practices is going to be obtaining PPE. This can be very challenging, as we all know right now, because of the pandemic and the high demand for PPE in a very short period of time. This has created shortages both in the United States and around the world. Of course, PPE really needs to be prioritized and rationed for healthcare providers that are serving high-risk patients, such as in hospitalization, such as in hospitals and facilities serving high-risk patients. So you do need to do your best, both in preserving and prolonging the PPE you have. So you want to use it sparingly. You might want to reuse, in some cases, through cleaning and disinfection, and really prolong the life of PPE so you can extend it. Your practice will need to invest time and effort in identifying various sources to obtain PPE. This can range from many different avenues. The biggest one right now is likely the online sellers of different types, but also there are other industries and other types of ways to obtain PPE. The construction industry has been using PPE, and particularly in terms of respirator masks. There are various sources for donations, maybe other types of practices that maybe have not opened yet, like dental or veterinary, might have PPE that they could spare. Medical spas, TV shows, vocational schools, even tattoo shops that might be closed down might have PPE that they could spare. So you have to be creative. You have to be very creative. I would be careful, though, with internationally sourced PPE. They may be held up in customs. FEMA can confiscate PPE. So you can order it, think it's coming, but it might never come. So if you are going to use the different types of sellers, try to utilize US-based resources and online sellers that have guaranteed delivery, and check their seller reviews. That might help a little bit as well. But it is a very challenging issue. So the types of PPE, again, they are to, the first type is really to protect the entry or exit of virus through the nose or mouth. The best type of PPE for this purpose is the filtering face piece respirators, or FFR. The most common one that you've heard about, talked about widely, is the N95. This is really important for aerosol generating procedures, or when you're dealing directly with high-risk patients, or patients obviously who are known to be infected, but in the ambulatory outpatient community-based practice settings. Again, if you follow all your other safety procedures and screen out patients that might be symptomatic, you're going to reduce the risk of patients that could potentially spread virus, though of course there is this issue with asymptomatic infected individuals who still might be able to generate and spread virus. But N95s are in very short supply. There are some equivalent N95 type products, FFP2, K95, P2, DS2, and Korea First Class are some of the ones that I've seen listed as equivalent in terms of the ability to filter out a viral particle such as COVID-19 or SARS type viruses. These other equivalent products are not necessarily US regulatory standards, but they, in this climate that we're in right now, can be acceptable alternative if N95s are not available. But for most office-based situations, again, if you've screened out patients carefully, face masks are an acceptable alternative and more readily available. And they're really sufficient for many forms of patient contact, such as maybe you're in a room consulting a patient, maintaining your physical distance, but not actually having any direct patient contact. However, if you're doing a procedure, maybe an EMG or an EEG, where you have direct patient contact that's more prolonged, you might want to consider a higher level of PPE. But face masks also help to preserve higher level PPE, such as the N95s, and these type of coverings are good for patients. Now, there are also cloth masks that you're quite aware of, people making them even at home. These are not considered true PPE for healthcare providers, but you might want to consider them, particularly if you can't obtain proper PPE or you have short supply. You might want to consider them for staff who do not have direct patient contact, people that might be accompanying patients, healthcare providers to try to preserve and prolong the life of their PPE when they're not actually interacting with patients might want to take off their PPE and put on a cloth mask, and other situations that are sort of low risk. Cloth masks should not be used for children under 2 years of age, however. Then there is the concept of protecting your eyes, which can be an entry point for virus. Face shields or goggles are most commonly used. These are often reused because they can be cleaned in most cases. Then there's, of course, hand protection. Again, not a substitute for hand washing, and you should wash your hands before and after donning gloves. But the gloves that can be used don't have to be sterile for the most part, unless you're doing a procedure that requires sterile gloves. They're, for the most part, are disposable, but you just need clean gloves. And then isolation gowns. These could be disposable type. They could be the type that can be laundered if you have the availability and practice that has access to launder such materials. And then you might want to consider shoe covers or head covers, possibly setting up a bin at staff entrance, for example, to put on shoe covers. Now, these are not absolutely necessary, but again, if you want to try to reduce all chance of picking up virus from different surfaces or bringing it into the office, this is a good idea, both for staff and also for patients as well, possibly giving them a shoe bin, and then they can put on maybe some disposable booties or disposable socks. And if people have long hair, that could brush up against the patient, for example, and maybe or a surface and pick up virus. Head covers would be advisable as well. So for cleaning, there are very good guidelines on the CDC website for facility cleaning. But you should really try to develop good policies and procedures for cleaning rooms, furniture, and equipment throughout the day. And if you're using overnight cleaning services for an office, communicate with them and see what their cleaning protocols, what type of materials they use, and also how they protect their cleaning crews. What do the cleaning crews wear? Because the cleaning crews are going to come from other offices as well, and they're going to come into your office. So you want to make sure that there's a proper protection in place for that as well. But in general, you're going to clean high-touch surfaces and equipment very often, as was alluded to before. But be careful with your delicate electronics. Check with the manufacturer how they advise cleaning equipment to eliminate virus. But also there's different types of covers you might want to use for different types of equipment that are wipeable and cleanable. In general, for surfaces and other types of, and sometimes even for equipment, you might want to consider using soap and water prior to disinfection. And then for disinfection, make sure to use gloves and adequate ventilation, because the cleaning solutions are quite volatile, and over time during the day it can build up. So also to be sure you have adequate stock of all the cleaning solutions, and also don't forget cleaning materials. Don't forget paper towels, spray bottles, receptacles, laundry bins, and of course hand sanitizers and hand washing stations should be readily available. For offices that have soft cover furniture, you might want to consider wipeable or removable furniture covers, or use soap and water after the use, and you might also utilize different types of cleaning solutions that are EPA designated. And for the cleaning solutions that can destroy the COVID-19 virus, the ones that are advised by the CDC are a water to bleach solution. It's a 4-to-1 concentration. You should leave it on the surface for at least 1 minute or more before you wipe it off. But one problem with these solutions is they're only potent for approximately 24 hours, so you have to remake them on a daily basis. An alternative is 70% alcohol solution. It doesn't necessarily need to be wiped off because it tends to evaporate. It's probably a better option for different types of equipment where bleach can destroy the equipment. And again, it depends on the availability of all these products, what you might want to use. But those are the two main ones for that are known to kill the COVID-19 virus. So testing is a very big topic, as everyone knows. Testing is very useful for epidemiological studies. Testing for the presence of virus, or testing for antibody production, meaning that you've been exposed or infected with the virus at some point. It's very useful for epidemiological studies, necessary for mitigation and contact tracing, necessary for hospitals and high-risk facilities, and necessary for various types of medical and surgical treatment decisions. However, for community-based ambulatory healthcare facilities, and also many types of outpatient facilities that may not be necessarily community-based, there's no direct federal guidance at this point. There's variable state and local guidance. And really, this situation is probably going to change as we go forward, as there's more availability and accuracy of the viral rapid test in particular. So guidance may change. For those that have individual, independent private practices, there's a lot of issues with in-office testing. Any type of test of this nature, you're going to have to be able to provide pre- and post-test counseling. You might have to have certain types of equipment for the test to develop the test, if you will, and with various types of lab space. There can be false positives and false negatives. Testing results can vary day to day on an individual person, depending on when they may have been exposed and the incubation of the virus. And there's always a question of who to test and how often to test. And lastly, to talk about communication with your patients. You need to set expectations. The patients need to know that they may be coming into the office and not be allowed to be accompanied by someone. Family and other members may have to wait in the car or outside the office somewhere. They have to make them aware of all these safety and care plans that were discussed today. It's a new experience, a new normal. It's not going to be the same office visit that they're used to. And if they have expectations, there'll be less anxiety once they reach you, and less questions. You need to reduce the fear and emphasize the positive. Emphasize your commitment to patient safety, and that you've always had practices for infection control, but now you're really going according to guidelines from federal and state authorities, as well as your own practice policies and procedures. But be honest. There's no plan that can provide total elimination of risk. In healthcare facilities, there's always been, and even with universal precautions and all types of use of PPE, there's always a risk of infection. But you could be, confident and express to your patients that your office plan is designed to minimize risk and adheres again to federal and state guidelines for healthcare facilities. Consider developing what I call social stories, especially for children and adults with special needs. A trip to the office in general can be anxiety provoking, but if all of a sudden they encounter people dressed in all these PPE and masks and gloves, that could just provoke anxiety to a higher level and cause a lot of difficulties. But if they're prepared by seeing pictures of your staff in their PPE, seeing pictures that their temperature is going to be taken, and other changes to the office routine, that can make a much more pleasant and viable visit. And because a lot of times, especially with children and special needs, and also for patients in general, that they might be in the visit individually and not accompanied, utilize technologies, iPads or phones with FaceTime and other means of communication, so that they could talk to the family member that's outside the office, and that family member then could also talk to the healthcare provider, asking questions and other things that they might have to communicate, or maybe history that you need to get from them. And develop communications in different ways, depending on your individual situations. If you have a website, post a lot of these communications on your website, utilize social media extensively. Be positive again that you're expanding accessibility and services through your office reopening and the continuation of telemedicine if you've already launched telemedicine, or if you haven't already, to consider launching telemedicine. So there are some positives that come out of this. Communicate to your patients through these different means about state and federal guidelines, if applicable, that you may be waiving their copay and coinsurance. That's something that they would like to hear very much, especially when it comes to telemedicine. Recognize that many patients and families are undergoing extreme stresses in this pandemic, due to quarantine, job loss, and other issues, maybe illness and maybe COVID-19 infection that they've had to deal with within their family. And provide on your communications different internal or external resources where they can seek help if needed. Develop patient handouts about all this, and utilize office signage. Have postings that, hey, neurology office is an essential healthcare provider, and that's why we're reopening. For some reason in March, overnight, the entire field of neurology was rendered as non-essential. So we have to get back into this consideration and mindset that there are essential and non-essential healthcare services. There are acute services that are necessary in a pandemic, but now we're at a phase, as was talked about by Dr. Betty, that we have to get back to reopening offices and providing care. And also office signage could talk about the rules for patients and families, CDC guidelines, and other postings. And lastly, consider developing consent forms. Consent forms for telemedicine, but also consent forms that they're for people that are now agreeing to receive services in center-based situations back in the office, so they understand all the issues and what you'll be providing, but there's never a total elimination of risk.
Thank you to our presenters for that wonderful presentation. And before we get into the Q&A portion, I just want to remind people that we have a lot of great resources on the Academy website in our new COVID-19 resource area, including a new page that just went live late yesterday for all of the reopening your practice resources. So check out these sites for telemedicine guidance, financial support guidance, and if we don't have time to get to your question today, you can always send questions to practice@aan.com. So although we're at the top of the hour, we are going to go long. So I hope people can stay on because we have a lot of really good questions to get to. Now I'll invite all of our panelists to join me in answering questions. And we have Dr. Gee joining us. And I'll actually have the first question go to you. Thinking about, and we saw from our poll, we have a lot of solo practitioners on the webinar today. So what guidance can you give practices in small private practice about how to right size bringing back employees?
So thank you to my colleagues. That was an excellent presentation, and the details that they presented are applicable for all sizes of practices. In particular, the small and solo practices, we have to think about the communities that we practice within and the risk within those communities, and really focusing on the safety of the patients. And that's what this whole process is about, is being able to facilitate the appropriate care to the patient at the right place, the right time. And so in right sizing a small practice, if we continue to stratify the patients in a way that minimizes the risk, identify those patients that we can continue to see with telemedicine, be able to use our staff in a way from remote sites that they can still communicate with the patients, we can be improving the access of care to those patients. We also then can choose which patients are necessary to be seen and which ones can be safely seen in the office. And so talking specifically about the in-office patients, we want to minimize those that might be symptomatic. We protect ourselves as best we can with the asymptomatic patients that we know are out there. But the staff in the office are going to be just the minimum number and the appropriate ones necessary for the safety issues, the cleaning of the office, as well as the patient flow. By doing this, you can scale in just the appropriate staff that you need, and it may be 1 FTE per provider to facilitate that, where the rest of your workers are working remotely, or it may be more, depending on the size of your practice. And if we do that, then we scale up as we can. So the bottom line is that it varies depending on your practice, where you're at, what the community risk is that Dr. Betty talked about, and then make the decisions that are appropriate for not only you, the safety of your staff, but the patients that need to be seen in person, whether you're doing procedures on them, but stratify it as best you can, provide the staff necessary to support that process.
Great, thank you. And then we got a lot of questions about, starting to do procedures and how to do that safely. So I'll ask Dr. Betty, we had questions about how do you reopen an EMG practice and what precautions should be taken to safely do EMG for both the patient and the provider.
Got it, yes. So EMGs in certain circumstances are quite essential. Quite honestly, I just did an EMG this morning and had called me a month ago, and I had deferred it, but called me again today saying that some of his weakness had progressed. So we needed an EMG to be able to decide what to do next with him. The American Academy of Neuromuscular Medicine, the AANEM, has very good guidelines about EMG practices. It is the difference between doing an EMG and seeing a patient in clinic is quite honestly mostly about the amount of patient contact and about the duration of patient contact. A typical EMG might take anywhere between half an hour to an hour, in this case, to even longer, depending on how an EMG is done. And the physical barriers between patients and providers are slightly less intact as compared to seeing somebody in office. So to do that, we used gowns, we used a face mask, we used a face shield. We created a plastic barrier between the EMG machine and the patient. The patient was requested to wear a mask and gloves during the whole procedure so that they would not pass, fomites and particles to the room. And obviously we use disposable electrodes and disposable needles, and we use cleaning supplies slightly more diligently than we were using before. So again, an EMG practice can be reopened. The AANEM probably has the best list of what should be done.
Right, and that's a great point. The AAN is linking out to those sites. So if they're AANEM or sleep medicine or other groups are starting to provide that type of guidance, that's what we have on that new reopening page so that people can find within a certain subspecialty or procedure area. So we also got a lot of questions about PPE, so I'll start to throw some of them out. Maybe Dr. Ryder-Deemer, you want to start? What are the exact items of PPE we should have? Should we have a gown, a head cover, a shoe cover? Should we wear full PPE even when seeing a patient in the outpatient department? And then, not to overwhelm you with too many questions, but how would you calculate PPE requirements, say, for a staff of 18? And for what duration should we be buying it?
Wow, okay. So let me know if I'm missing some of them along the way, and I might refer some of these to Dr. Mintz, as well. But it depends upon which part of this you're addressing. So in other words, the people that are screening the patients, oftentimes are wearing goggles. They are wearing, sometimes if they have long hair, a covering over their head. They are wearing masks. They are wearing gowns. And they are wearing booties over their shoes, and the gloves have been recommended but not mandated per se, and those are the people checking in patients at those booths that I had explained. That is a little bit different than other individuals within the workplace. This isn't an exact answer, but I think it's the most logical one, which is you have to determine how often an individual is interfacing with a patient and what are your resources. So for example, my husband's an ophthalmologist at UCLA here, and they all have plastic barriers for where they come in. So with that plastic barrier, the individual that's receiving, let's say, a co-payment or whatnot, is also wearing a mask. And oftentimes they're sanitizing their hands or changing gloves in between. If it's more minimal than that or more maximal than that, you do have to vary it that. If there's an individual that you're suspicious, maybe they said no to the symptoms and they didn't have a fever, but now you're, hearing them cough, you may take more extreme levels and go from stage 1 to stage 2. If there's a procedure going on, even though they may have answered the questions in that way, you always would need to be mindful with that. In terms of the number of PPE, this is just such it seems like such an overwhelming question, but really if you bring it back down to the surface, and that's where I said is when you look at it in your huddles the night before and you think, okay, we've got 50 patients coming in as an example. And of those 50 patients coming in, what are their ages? Are any of them immune compromised? What is their status? Or some needing, assistance with walking more than others, so that the time duration, you need to be mindful of that. You do need to think of that with how you schedule them, which gets back to my enter and exit coordinator as an example, whatever you want to call it, to make sure that you have the ratio to suffice that. Once you have that number and who's being scheduled, you have to figure out when they're going to be scheduled. And again, it gets back to video and in-person visits. Again, sticking to the in-person visits, once you have that number down, you're going to quickly see how you just start to develop a method of how much PPE you're going to need in those designated areas. And then you have some backup in case there's a couple surprises. So there's not really, I can't say a magic number, because whether you had a private practice and you're seeing 20 in one day, or it's an academic setting and you're going to be seeing 75 patients in a day, is obviously going to dictate the number with that. But I think try to just keep it as focused as you can. How many patients are coming in? Who has the most interaction? Give PPE accordingly, and then make sure in your huddles that you always have plan B and plan C if things don't work, and making sure that you have sort of a command tree, if you will. Who's on deck that day in clinic for urgent matters? And if they're not there, who's the next person? Zoom can be on your iPhone. You can do a prompt 1 Zoom visit with everybody there saying, hey, you know what? This patient took a half an hour longer than we thought. We need to keep the other one out there. Let's bring them in. This one said no, but I thought I might have heard a cough. Let's have everyone put this on as a level 2. I guess that's how I would best answer all that.
Good, thank you, great advice. So now for Dr. Mintz, we've been getting a lot of questions about testing before procedures. So one question was that COVID-19 testing is required in their area prior to MRIs and CT and ultrasounds. The question is, should we be requiring COVID testing for patients prior to in-office procedures like EEG, EMG, or botulinum toxin?
Well, there's no specific mandates from a federal level that I'm aware of. Certain local or state guidelines might be different. I'm not aware of all the states and local guidelines. But the bottom line is, the issue is the concept of universal precautions. Again, we're minimizing the entrance of symptomatic patients into the office. Again, there may be people that aren't necessarily being totally honest on the pre-screening questionnaires. They might not have fever. They might have very, very mild symptoms or no symptoms and still be infected. So we have to assume, just like we've done for other types of pandemics in the past, that you may be dealing with an infected spreader, so that you take universal precautions. So whether or not they're COVID negative, you're still going to use universal precautions, and because it may be, depending when they got that test, and the chance of you having in an individual office a rapid COVID-19 test that's reliable, that the negative is not a false negative, you still have to assume that they potentially could have a variant of symptoms that could potentially make them infectious. So the concept of universal precautions, for now, I would say, is the way to go. Once we have more reliable testing, available testing, that's also an issue of cost effective and can be done on a frequent basis, that might change some of the guidance. But right now, it's all about universal precautions and assuming that somebody could potentially be infected, regardless of what their test is.
Right, thank you. So Dr. Betty, we have international participants on the webinar today too. So we had a question about, do we have suggestions for what to do in India or Bangladesh?
Yep, so that's a great question. About what, a third to half of our members are international. So that's a very relevant question for all of us to think about. I am from India, so I am following the India COVID rates. They thankfully have fewer numbers as compared to the United States, but the disease is on a rise. I would say that the paradigms that we talked about, similar paradigms apply to India as well. I am not fully aware of what the testing availabilities and what PPE availabilities are, but quite honestly, the various barriers that you have in front of you to prevent COVID transmission, whether it's from the patient to you or you to your patient or to the staff, are the same. Number one, make your decision the right way. Have a good high-level operational understanding of where your local geography stands. Where does your institution stand? What are local resources available? If you have good available resources to be able to take care of patients, then yes, you should absolutely bring in necessary patients and see them. The amount of PPE required would be exactly the same. That is all I can reiterate here. There are several international organizations that I am aware of who are supplying PPE to several hospitals. One thing that I have seen come up through the AAN and in other groups is there are people kind of sticking together and grouping together to help each other with telemedicine resources and remote care resources that were not available and not fully understood before this crisis hit us. So again, try telemedicine, try to make your decisions in a smart way, and then use PPE when you do have to physically see a patient.
Great, and then I think we'll do one last question, but before I ask that, I just want to acknowledge we had a lot of great questions that came in that we don't have time to ask, but this is all rapidly evolving, and those questions help the AAN understand what additional resources or articles that we need to develop. So we will address the questions that have come in, and those have been really helpful. So just for the last question, I think we'll go back to you, Dr. Betty, for this final one, asking about the duration for cleaning practice.
Got it. This is an extremely complicated question for two reasons. Number one, our clinics are not designed to be very sanitary spaces. They're designed to be highly sanitary spaces, but they're not designed like ICUs and ORs are. And the second thing is, obviously there's a great variability in the building structure of our clinic spaces. In our institution itself, we have clinics that were built in the 1950s, updated in the 70s and 90s and 2000s, and then there are clinics that were built literally last year. So there is a big variation in the actual building structure. So to roll out one set of guidelines for everyone is hard. But the couple of things that we should think about are, number one, as Dr. Mintz talked about, cleaning after every patient is important. And the cleaning needs to be slightly more thorough than before. Surface transmission is the single biggest method of transmission of COVID. So cleaning surfaces is very important. Allowing your disinfectants to stay there for a few minutes is more important than actually rapidly wiping through a surface. So that's very important. One question that I saw prop up was about electrostatic cleaning. I have not seen that in any CDC guidelines, nor have I seen it in any official guidelines anywhere. I don't quite fully understand what that process is, so I'm not going to address that. The third question that came up was about air exchange rates, and that's actually a very fascinating topic. There are two kinds of air exchange systems that are utilized in medical facilities. There's a positive pressure airflow system, which kind of, if I can explain it better, it's kind of like using a leaf blower to push air into a room and then push and to recirculate it so that a certain amount of air is then obviously by pressure pushed out of that room. That kind of system is utilized in most ORs, I want to say across the world. And that really works well for when splash contamination and droplet and liquid contamination, fluid contamination is of importance. The second method of air exchange is actually negative air exchange, where a certain amount of air is sucked out of a room, and to replace it, there is an inflow system that comes into it. That's how we utilize air exchanges in most of our clinic spaces and also hospital spaces. The air exchange rates vary. Air is exchanged every 6 to 8 minutes in ORs, and about 20% at a lower limit and 70% at a higher limit of air is exchanged every 6 to 8 minutes, which means that if you want to sanitize an OR, it's easy for you to replace more than 95% of the air inside the OR within a matter of 20 to 30 minutes. That doesn't exist on the clinic side. And even if it exists, I don't think that outside of actually doing an airflow exchange test, which is a quite cumbersome test, which requires you to completely seal a room and then measure droplet exchange rates, it's very difficult to actually determine what your room's air exchange rate is. So that's why air exchange rates vary between 12 to 15 on the hospital side and between, let's say, about 20 to 30 minutes for an air exchange. And the amount of air exchanged every 20 to 30 minutes is not 20% or 70% like in the OR, it's actually much lower. It can be as low as 2% depending on your atmospheric conditions. So that's what it is. What we should focus on is surface cleaning. And because air exchange is a giant topic that we really cannot change in our building structures, I would say that having about 30 to 40 minutes of gap between two successive patients would allow a significant amount, and I'm guessing that in our clinic that would be about 70 to 80% of the air in the room to be exchanged in that 30-minute gap. So that is actually an adequate amount of time. Of course, if you're in a very old building, you might want to leave it around for about an hour before the air is exchanged, or even longer. But it's a very hard question to answer.
One thing I just did want to climb in there, just because it came up on a few questions over here, if I may, was regarding EEGs and whatnot. In terms of EEG cleanings, you do need to clean down all of them, obviously, in between patients, and it's recommended for room air. But you do need to be mindful that you have to use the disinfectant at the correct concentration. So just be mindful that if you use bleach or other such thinners, you actually can crack or melt the plastic surfaces, and you wouldn't want to do that. So again, just to be mindful of not only wiping them down, but making, as the manufacturer, the directions on that, so you don't actually ruin the devices and create a short or something on another patient.
Great, thank you. So we are going to conclude the webinar at that point. I want to, on behalf of the AN, I want to thank all of our panelists for a great presentation, and thank you to all the participants who joined today.